We go one by one with these scientist name. If I say Hans Berger discovered EEG. Hans Berger ने EEG की discovery करी थी, not ECG. It is electroencephalography. So EEG के अंदर जो waves होती हैं, the waves in the EEG, these are also called as Berger waves. If I say William Einthoven discovered ECG. This is the question that you should remember. William Einthoven is a scientist who discovered ECG. So we call this as pioneer or father of ECG. Okay, if I talk about other options, if I say Paul Ehrlich, if I say it is considered father of chemotherapy, and Hippocrates is called as father of medicine. So understand this simple basic question, who discovered ECG? The answer is Wilhelm Einthoven. So this is the answer. चलते हैं अगले क्वेश्चन पे. P wave in ECG. So as you know, you can see this first wave in ECG. This type of wave is called as P wave. First wave, जो पहली wave आती है, that's called as P wave. So if I say this first wave that you see, this first wave, P wave, it is due to atrial depolarization. So just understand this. Whenever there is atrial depolarization, you will see P wave. Atrial depolarization के बाद, after this you will see ventricular depolarization. Whenever you will see ventricular depolarization, then understand this, you will see QRS. This QRS complex, you will notice this is QRS complex जो आ रहा है, that QRS complex is due to ventricular depolarization. Then understand this, the third wave you will see T wave. T wave is due to ventricular repolarization. T wave, you will notice this T wave. This is due to ventricular repolarization. Last, in some ECG, you will notice there is repolarization of papillary muscles. Because of the repolarization of papillary muscles, you will notice there is one more wave. That wave is called U wave. So understand this. This wave you will see sometime in some ECG. We call this a U wave. So if I label this ECG strip like this, this will be your P, Q, R, S, T, and U. So understand this once again. एक बार फिर समझ लीजिए. If I say P wave is the first wave, and this represents atrial depolarization. Atrial depolarization. If I say QRS, this QRS, complete QRS, this is due to ventricular depolarization. Ventricular depolarization. Then you will notice T wave. This T wave is due to ventricular repolarization. And sometime in some ECG, not in all ECG, you will notice there is repolarization of papillary muscles. And because of this, you will notice the patient will get in the ECG UVs. So these are the waves that you should remember. चलते हैं अगले क्वेश्चन पे. ECG machine run a standard rate. This is the basic question, easy question, just one liner type of question that you should know. The basic standard rate you will see that is 25 mm per second. This is 25 mm per second. This is the basic rate. So if I say in one small box, if I say some more questions that they can ask in exams, you can see one small box that is equal to 0.04 second. 0.04 second. अगर मैं आपसे बोलूं एक बड़े बॉक्स में, in one big box, so you can notice this is one big box. 1, 2, 3, 4, and 5. You can see 1, 2, 3, 4, and 5. So this one small box is equal to 0.04 second. So you can notice these are, if I label this 1, 2, 3, 4, 5. 1, 2, 3, 4, 5 means if I ask you in one big box, अगर मैं आपसे पूछूं one big box, how many square, how many box you can see? You can see 5 small box. You can see 5 small box, right? So if I say this 5 multiplied by 0.04, so if I say the distance of this one big box, this will be 0.2 seconds. So these are some other questions that they can ask, or these are some expected questions that they can ask in your exam. Coming to the next question. So understand this, the question क्या question बन सकते हैं यहाँ से. ECG machine runs at a standard rate, that is 25 millimeter per second. One small box 0.04 and one big box will be 0.2 seconds. If I say what is normal PR interval, again a one-liner type easy question. To understand this, normal PR is considered in the range of 120 to 200 millisecond. 120 to 200 milliseconds. So answer is clear. Answer is A in this. Sometimes they can ask you a question on normal QRS. So this is your normal PR. Normal PR interval. If I say what is normal QRS, so if I say the distance in front of you, that is 80 to 120 millisecond, this is considered your normal QRS. Normal QRS. So understand this, QRS can be more than this. Then we call, there is some pathology in the ventricles. It's clear? Some pathology in the ventricles. So if QRS is more than 120, that is called as, if I say QRS is more than 120 millisecond. So don't get confused. In some books you may see the answer 100 also. So understand this, if it's more than 120 millisecond, then we call this there is some defect, or there is some pathology related to ventricles, so ventricular origin. Coming to the next question. If I say calculate heart rate given in this ECG, so heart rate calculation, so you can notice this. We have two things, like either you can calculate this RR interval, the difference in this RR, the number of boxes you can calculate, like big box 1, 2, 3, 4, 5, 6. You can see there are 6 boxes, so we have a formula to calculate this. You can see the rate, the rhythm of this ECG is followed by QRS. So you can say this is a normal regular rhythm. So in this case, what you'll do, you can apply the formula 300 divided by RR interval big box. To be more accurate, you can use 1500 divided by RR interval. To be more accurate, you can use the formula 1500 divided by RR interval, and this RR interval, now you will calculate small box. If you calculate this, if I say 300 divided by big box, means you can notice 1, 2, 3, 4, 5, 6. So there are six boxes, right? Six boxes you will notice. 1, 2, 3, 4, 5, 6. So you can see 6 boxes. So if I say the answer in this case, this will be 50 beats per minute. So heart rate will be 50 beats per minute. This is the heart rate, how we calculate. Now sometimes they ask a question related to axis. So understand this, in axis what you can see 2 leads. Basically you can see lead V1, lead 1 and lead AVF. So these are the leads that you can see. So you can notice if you see, I told you can notice here. If you see the first, let me say how to calculate the heart rate. So heart rate formula in this ECG, you can see 1, 2, 3, 4. So let me see once again, there are 1, 2, 3, 4. So there are 4. So if I say 300 divided by 4, so heart rate in this ECG will be 300 divided by 4. So heart rate will come how much? This will be coming around 75. Heart rate will be 75. So understand this, what you need to see in the axis. So what you need to see in the axis, you need to see the deflection of your QRS. You need to see the deflection of QRS. So let's see, if I say, you can notice in lead 1, you can notice this, there is a negative deflection. You can notice in QRS, this is going towards downside, that is negative deflection. Or let me say the arrow, it is going down. And if you notice in AVF, you can notice it is moving up. It is moving up. So you can notice they both are reaching each other. So remember this formula, right reaches, left leaves. Right? So this is, they are reaching towards each other. So this is your right axis deviation. Right axis deviation. So this I have discussed in detail in the normal lectures. So understand this, understand this, what we can say, you can notice this is what we call right axis deviation. This is an ECG of right axis deviation. Okay, if I say what about QRS in this ECG? So understand this, QRS, you should understand this. What is importance of QRS? You can notice, I told you the normal QRS, if I say the normal QRS, it is how much? Normal QRS how much? It is 80 to 120 millisecond. This is around 2.5 to 3 boxes. So I can say this is maximum 3 box. It is around 3 box. But here you can notice the QRS. This is the QRS. So let me highlight this. If I can say the QRS here, this is coming in only 1 box. This type of QRS, it is less. So understand this. This is what we have. We call it, this is narrow QRS. So this question just I made intentionally to explain you about the other ECG findings. So understand this. This is a normal QRS. This is a narrow. So this is the narrow QRS. Okay, then we have spot diagnosis. Sometimes they ask a question on spot diagnosis. So understand this question carefully. First thing is, what is important in ECG is you should be looking at QRS before then P. So my point is you should look at QRS before P. So if you want to be sure in making diagnosis, you should look at the QRS. So you can see this. So I'm not looking at the P because I can't see P here. No clear P is seen. So you can see the QRS that is coming less than 3 box. Less than 3 box means it's coming only 1 box again. So this QRS is what? This QRS is again a narrow. So just I can figure out the answer. Understand this. This is a narrow QRS. So I don't know what is the answer, but I can say this is a narrow QRS, right? So understand this. It can be a narrow QRS or narrow complex QRS. So understand this. This narrow complex QRS you can see whenever there is a problem above the ventricles. Above the ventricles means the problem is somewhere in the atrium. So we call them supraventricular arrhythmias. So these are supraventricular arrhythmias. There is no problem in the ventricles. If I say wide QRS, means that is more than 3 boxes, more than 120 millisecond or more than 3 boxes. This is wide QRS. More than 120 millisecond, or I can say 3 box. Then I can consider the pathology somewhere in the ventricles, means there is some pathology related to the ventricles. So why I am telling you this, how to approach a question, understand this. In this ECG you can see there is some pathology. So if I tell you to calculate the heart rate, you can say calculate the heart rate. They are coming around 2 boxes. 2 boxes means heart rate will come close to 150. Heart rate is coming close to 150 means there is an arrhythmia. Am I clear? There is an arrhythmia. So understand this. In angina, you will see classical ST elevation or some changes in the T segment, ST segment or T wave. So angina is not the answer. I told you this is QRS is narrow. So ventricle pathology are ruled out. So there is no ventricular pathology. This is no ventricle problem. Now we have 2 options: AV block and atrial flutter. AV block means atrioventricular. There is again some ventricle word is coming. So ventricle problems are ruled out. The answer will become atrial flutter. So this is sometimes you can mark the answer when you are even not knowing anything. So understand this, you are knowing now, but you should be knowing. Narrow QRS means supraventricular. This can be seen in some conditions, like you can see this in atrial flutter. You can see narrow QRS or supraventricular arrhythmias origin, like you can see this in PSVT, paroxysmal supraventricular tachycardia. PSVT, paroxysmal supraventricular tachycardia. Supraventricular or narrow QRS again you can see in atrial fibrillation. And if I say the fourth one, you can see this narrow QRS in MAT. MAT means multifocal atrial tachycardia. So understand this. In our option, it was only flutter, so we mark the answer. But again, how we rule out? So understand this. This is this type of characteristic wave you can see in the ECG. These are the waves you can see in the ECG. These waves are called as sawtooth waves. So these are what? These are sawtooth pattern. Sawtooth pattern. So that is classical for flutter. But how to approach is understand this. In PSVT, you will see a regular RR interval. You will see there will be regular RR interval and there will be no sawtooth pattern. In atrial fibrillation, you will see more fuzziness. More fuzziness means you will notice this is sawtooth pattern, but instead of this, you will see like this. You will see this type of small, a little small. These small waves are called as fibrillatory waves. I'll explain to you again in the next question that we come. And understand this, in MAT, multifocal atrial tachycardia, you will see 3 different type of P waves. Means you will see more than 3 different type of P wave. More than 3 different type of P waves. For this you will notice more than 3 different type of P waves. Okay, coming to the next ECG, let us see one by one. You can approach this simple question. These are very easy questions. So if I say identify the given ECG, so you can notice again. Now you can notice what you need to focus. I told you focus on QRS. So if you focus on QRS, see QRS. If you notice the QRS, this is coming bigger. right? If you notice, this is what QRS. So if you focus on QRS, what you can notice? You can notice this is broad QRS. But along with broad QRS, you will notice the QRS is getting broader. QRS is broad. QRS is broad. When QRS is broad, along with this, you will notice there is no visible waves. So understand this one by one. There is a broad QRS and there is no visible P waves. So I can say there is no P waves. P waves are also not visible in atrial fibrillation and flutter. Sometimes they are also not visible in flutter. But in atrial flutter, I told you there will be narrow QRS. You can notice there will be narrow QRS like this. So understand this, atrial flutter answer is ruled out. MI, you will see ST segment elevation. So that is classical. I think many of you are already knowing this. MI is ruled out. Torsades pontis, I'll tell you a little later. So understand this is what we call this. This is what we call this is broad QRS with no visible P waves. This is your ventricle origin. So just I can say here, I want to tell you, like you can see wide or broad QRS means the problem is where in the ventricles. Means the problem in the ventricles. Wide QRS means it is telling you there is some problem with the ventricles. When you notice some problem with the ventricles, then it can be what? It can be a problem like it can be ventricular tachycardia. Right? It can be ventricular tachycardia. It can be torsades. It can be torsades. And third thing, it can also be your ventricular fibrillation. So fibrillation means, ventricular fibrillation means again you will see fibrillatory waves. You will see fibrillatory waves, right? In ventricular fibrillation, you will see this type of fibrillatory waves, and you will notice there will be unidentifiable QRS. Means you will not know where is the QRS. So that I'll tell you later on. There will be unidentifiable QRS. If I say in torsades you will see more than 3 type of QRS. Like in MAT, you will see more than 3 type of P waves. In torsades, you will see more than 3 type of QRS. So what is left? You can see there is no visible P waves, and this is you will see. But if you notice the PR interval, if you notice the RR interval, sorry, not PR interval, RR interval, this is becoming regular. So this is what we call this ventricular tachycardia. So this is the ECG of ventricular tachycardia. Okay, coming to the next question. So these are some different questions. Just try to understand this. Identify the ECG. So first thing, what you need to check, you need to check is QRS. So QRS is narrow. Simple. QRS is narrow QRS. So ventricle pathologies are ruled out. Simple. Ventricle pathologies are ruled out. QRS is narrow. MI, you will see ST segment changes, ST elevation, right? ST elevation, ST depression. So this is what we see. You will see some T wave changes. This is what supraventricular tachycardia. If you remember, just come back to this. I told you before, narrow QRS you will see there, supraventricular origin, and it is seen there in PSVT, flutter, atrial fibrillation, MAC. So I have shown you flutter, PSVT. Clear? Okay, coming to the next ECG. Coming to the next one, if I see this is identify the ECG. So here, just I am giving you the hint. Just try to understand this. Just try to understand this. You can also notice here, this is also there is a narrow QRS. You can notice there is a narrow QRS. That's one box. So there is a narrow QRS. What else you will notice? You will notice asystole. You will see a flat line. Asystole, you will see a flat line. So this is not the answer. And MI again, you will see ST segment T wave changes. So it's not the answer. In flutter, I told you, you will see sawtooth waves, sawtooth pattern. So flutter is not the answer, right? Then you can notice here, the question is itself highlighting you that you can see this is a P wave, right? Which is going like this. You can see the second P wave, which is a normal P wave. And you can notice the third P wave like this. So you can see 3 different pattern of P waves and 3 different pattern of P waves. Here you will see, just come back to our thing. This you need to write down if you have not done. So I have told this in the normal video. So understand this is more than 3 P waves. That is called MAT, multifocal atrial tachycardia. So this is an ECG of MAT, multifocal atrial tachycardia. Okay, coming to the next ECG. If I say what you can notice again, you can notice narrow QRS. Simple. Again, you can notice narrow QRS. So see, MI, ST segment T wave, some changes you will notice. Torsades and ventricular fibrillation. Torsades and ventricular fibrillation, these are problem of the ventricles. And I told you narrow QRS. When you will notice narrow QRS means it is a problem of atria. And these waves which you notice here, these are called as fibrillatory waves. So you will see these are called fibrillatory waves. And you will notice along with fibrillatory waves, you will see there is no visible P waves. Can you see P waves? No visible P waves. So there is no visible P waves. So this is what we call atrial fibrillation. So remember this question they ask generally in exam. P waves are absent in atrial fibrillation. In which drug toxicity this type of ECG is seen? So understand this. This type of, you can see the QRS. QRS is broad. QRS is broad means there is some problem in the ventricles. Some problem in the ventricles, right? When QRS is broad means there can be ventricular premature ectopic beats, ventricular tachycardia, there can be ventricular fibrillation, right? And there can be torsades. That is more than 3 different type of QRS. If you notice in the ECG, more than 3 different type of QRS. So this is what we call this torsades. And torsades du Pontis can occur in a patient. You will see torsades du Pontis can occur whenever you give a high dose of digoxin. Sometimes due to digoxin overdose, patient can develop torsades, right? Okay, coming to this ECG, if I say how to diagnose this ECG, so you now understand this. Now QRS is broad. You can notice QRS is coming broad. QRS is coming broad, so means pathology is somewhere in the ventricle. So let me rule out atrial pathology. So atrial pathologies are ruled out. PSVT is also atrial pathology, so atrial pathology is ruled out. Torsades, I told you more than 3 different type of QRS. So torsades will look like this. So you can notice torsades will look like this. And so this is your, again, some fibrillatory waves, but this is not atrial fibrillation. This is your ventricular fibrillation. This is your ventricular fibrillation. So this is about your arrhythmias, which I have covered, right? So basically tachyarrhythmias, which I have covered, narrow and broad QRS based on this. If I say the next one, diagnose the given ECG, that is pretty simple. So this is, you can see, this is called a flat line, that is considered asystole. So this is your asystole. Right? AV block will discuss subsequently. So understand this. Now see this ECG. Okay, so answer is already given. So try to understand this. Just calculate the heart rate. If you calculate the heart rate in this ECG, you will see, calculate the heart rate. 1, 2, 3, 4, 5, 6, 7, 8. So if you divide 300 divided by 8, 300 divided by 8. So this will be coming heart rate will come around 37, right? Heart rate will come close to 37. So heart rate is less than 60, means it is a sinus bradycardia, right? You can see this is considered a sinus bradycardia. So you calculate the heart rate, you can see heart rate is coming lesser. How to calculate? 300 by RR interval. To be more accurate, what you can do, you can calculate the small box like this. Small box you need to calculate. If you calculate the small box, then the formula will be 1500 divided by small box. One big box is having 5 small box. Okay, if I see this ECG, you can notice again sinus tachycardia. How to tell the sinus tachycardia? You can notice this is the patient. You can notice there is 1 box, 2 box, 1 box, 2 box. So if I say 300 divided by 2 box, so this will come 150. So heart rate in this will be 150 beats per minute. So this is your 150 beats per minute, right? Am I clear? 150 beats is sinus tachycardia. Sinus tachycardia. Okay, then see, let us see some other ECGs. If I see the next ECG, if I say, you can notice in this ECG, what you can notice, the patient is having sinus bradycardia. So now 1, 2, 3, 4, 5, right? 300 divided by 5. So you can notice the patient is having bradycardia, right? And if you notice the PR interval, this is PR interval is more than 300. When PR interval is more than 300, this is called your first degree AV block. First degree AV block. So PR interval is prolonged. There is prolonged PR interval, right? There is a prolonged PR interval, means origin of P to origin of QRS. The PR interval, you can notice this PR interval is prolonged, right? Okay, so understand this. In second degree AV block, we call this Vanke back phenomena. So second degree AV block, you can notice this is your progressively increase in PR. So this is first PR. PR is increased more, right? Then you will see what? You will see this is a normal beat. Then you will see a short PR after this. So I can say how to say this is also called a Vanke back phenomena or Mobitz one. So you will see there is a progressive increase in PR. Progressive increase in PR. PR interval is increased. Right? And you can notice PR is longest. This one is longest. before drop beat. This is your drop beat, right? This is your drop beat, right? Which is longest, and then ultimately you will notice PR is also shortest after drop beat. This type of finding you will see where in second degree AV block, that is Mobitz 1 or Vanke-Bach phenomenon. Okay, then understand this. Next question, if I say you will notice this here. If you can notice, there is a constant PR, right? So you can notice some beats are conducting. You can notice this is like constant PR. In those beats which are fully conducting, that is, I can say there is a constant PR. PR will be constant in conducted beats. Right? And along with this, you will notice intermittently. You will notice these are non-conducted beats. Means only P wave you will see. So along with this, you will notice intermittent non-conducted P waves. This type of finding you will see non-conducted P wave. This is where you will see where this type of finding you will notice that is seen in second degree AV block, that is also called as Mobitz 2. This is you will see there in Mobitz 2. Mobitz 2. So Mobitz 2. So this is also second degree AV block. Second degree AV block. Okay, if I compare to this, you can notice in this ECG, you can notice these are atria, a constant P, a constant P, that is called a constant PP, and a constant RR. Constant PP and constant RR. PP and RR both are constant, and you can notice the atrias are beating separately and ventricles are beating separately. So you can notice if you calculate the distance between RR, that is fixed, right? They are constant. And if you notice the distance between P, this distance between different P, that is also fixed. So this type of finding you will see there, and you can notice we also call this AV dissociation. AV dissociation means atria and ventricles, they are not beating properly. We call this AV dissociation. So this is seen where? This is seen in third degree AV block. This is seen in third degree AV block. So the patient is having severe bradycardia, and this type of AV block you need to treat by pacemaker. Okay, then you will notice this type of T waves. We call them peaked T waves. So these are what? These are your peaked T waves. These are your peaked T waves. Peaked T waves, right? Peaked T waves, or we also use the term tall T waves. The question they ask in exam is in which electrolyte abnormality you will see tall T waves. That is whenever potassium is increased. That is hyperkalemia. So tall T waves we see where in hyperkalemia. If you compare these T waves, right? If you compare these T waves with these T waves which I am mentioning now, to understand this, these T waves you can see they look like a tent. They look like a tent, right? They look like a tent. So this type of T wave, what we call this? We call this type of T wave as hyperacute T wave. Both are tall, but one is just tall. This is hyperacute. Hyperacute T waves, understand this. These are seen where sometimes you can see these where in a patient of angina, or these are early sign of MI. So understand this is hyperacute T waves. They come before ST elevation and MI. So you can see in angina or MI. This is hyperacute T waves. Okay, so understand this. They'll give you this type of question. So how to interpret this question? To understand this, you can see QRS. QRS, if you notice, QRS is almost close to normal. So it is not looking like an ECG of any arrhythmias. So in arrhythmias ECG, you will see QRS will be changed. If you notice P waves are also coming okay type, so not a much difficulty. Just try to focus. If you see by looking this ECG, you're straightforward. Your attention is going where? Your attention is going where? In V2, this is what? This is your hyperacute waves. You will see V2. You will see this is what we call this ST elevation. ST elevation you will notice in V3, in V2, in V4, right? So I can say this patient is having ST elevation. So just see once again, this is what we call ST elevation from S to T, V2, V3, V4. So you'll see ST elevation in V2, V3, V4, right? Am I clear? ST elevation, some ST elevation you can also see in lead 1, right? Am I clear? Am I clear in lead 1? And you can also notice these changes where in AVL. So these are ST elevation. What else you will notice? You will see, you will notice the reciprocal change. Reciprocal change you will see in lead 3. So let me see the lead 3. In lead 3, you will see ST depression. So I can say there's ST elevation in lead 1, and AVL with reciprocal change. Reciprocal change means opposite. With reciprocal change where in lead 3, right? So this is what we see. If you see reciprocal change along with ST elevation, this is classical ECG that you'll see in the patient of MI. So this is basically your enteroseptal MI. So that details will not ask in your exam. This is your myocardial infarction. Myocardial infarction. Myocardial infarction. So let me come to other question. If I see, you can notice while pacemaker catheter is being inserted, the client heart rate drops to 38. There is a bradycardia. What medication you will give? So understand this. Amiodarone, lidocaine, digoxin, we give for tachycardias to control the rate. The answer is only atropine sulfate. So we give in bradycardia. What we give? We give atropine. We give atropine in bradycardias. Clear? In bradycardia, what we give atropine. Okay, and now observe the following rhythmia on client cardiac monitor. What rhythm does the nurse identify? So understand this. Now, what to see in this ECG? If I say what to see in this ECG, you can see QRS. You can notice the QRS. QRS is broad. So QRS is broad. When QRS is broad, atrial pathologies are ruled out. QRS is broad. You can notice broad QRS. So atrial pathologies are ruled out. Now the question is, it is fibrillation or it is tachycardia? So understand this. Why? If you see there is unidentifiable, right? Unidentifiable PR and unidentifiable QRS. So you can notice there is no identifiable QRS. So this is in ventricular fibrillation. In ventricular tachycardia, I showed you before. In ventricular tachycardia, if you remember, let me show you once again. In ventricular tachycardia, what you will notice. So try to compare this ECG again. You can notice here there is no P waves, right? But there is a simple pattern, right? The QRS you can see visible, right? But in fibrillation, you will see there is unidentifiable. You can see QRS is visible here. P wave is absent, but QRS is visible. But in this ECG, you will notice there is unidentifiable QRS. So this is what we call this ventricular fibrillation. So this is the ECG of your ventricular fibrillation. Okay, coming to the next question. What nursing action should be included in a plan of care for a client who had permanent fixed pacemaker? Instruct the client that it's better to sleep on top 2 pillows. No way, there's no issue, no things to take 2 pillows. Encourage client to reduce activity from former levels. That is also we can do that. Teach the client to keep daily accurate record of pulse. That is also we can give. Inform the client that pacemaker function when the heart rate drops below a preset rate. No, pacemaker will always function. To understand this, what is the question they're asking? What nursing action should be included? Right. So understand this. The nursing action is you should teach the client. Option B is also good, but we have to choose the single best answer. So understand this. सबसे अच्छा आंसर क्या होगा? सबसे बेस्ट आंसर क्या होगा? You will notice a permanent pacemaker is fixed. So you should teach the patient that you should always keep a track on your pulse. That is to keep a daily accurate record of the pulse. Okay, a client is receiving continuous ECG monitoring while intermittent medication is being administered for premature ventricular complex. So some medication they have given. So what dysarrhythmia does the nurse see? So basically they're asking you look at the ECG and tell me the arrhythmia. So understand this. In this question, what you can see QRS is narrow or wide? Wide. QRS is wide, right? QRS is wide. So what I told you, when QRS is wide, atrial pathologies are ruled out. Simple. Now ventricular fibrillation, ventricular tachycardia. Can you see fibrillatory waves? No, there is no fibrillatory waves. So this is also not the answer. So answer will become ventricular tachycardia. Simple. ECG is very simple. Next question. If I say when a client develops ventricular fibrillation in a coronary care unit, what is the responsibility of the first care person? Whenever a person develops ventricular tachycardia or ventricular fibrillation, understand this. These ventricular arrhythmias, they are very lethal, they are very dangerous. ये बहुत ज़्यादा dangerous होते हैं. So understand this. Whenever you see these are lethal arrhythmias, they are very dangerous. There is no role of oxygen. There is no point of suscitation. Sodium bicarbonate, there is no role. Acidosis थोड़ी हो रही है. There is no acidosis. The point is, whenever you see ventricular fibrillation, you should do immediate defibrillation. So answer is the nurse should initiate defibrillation. Second last question. If I say a client who had myocardial infarction in the coronary care unit, MI हो गया. Nurse observe ventricular irritability on the screen. Ventricular irritability means ventricular tachycardia or ventricular fibrillation means some problem with the ventricles. I told you ventricular arrhythmias हमेशा कैसे होते हैं? Dangerous होते हैं. Ventricular arrhythmias are always dangerous. So what you should do to understand this, we have 4 class of drugs like anti-arrhythmic drugs. There are 4 main class 1, 2, 3, 4. So understand this, out of these 4 class, beta blocker and calcium channel blocker we reserve for prophylaxis. Means beta blocker, calcium channel blocker ये क्या करेंगे? ये rate control करेंगे. So we prefer them for prophylaxis. But यहाँ पे तो emergency, this is an emergency and this is a lethal arrhythmia I told you. So what you should give, the most common thing is you should control the rhythm. So understand this, amiodarone is a common drug that we use. So what we do to understand this patient should be immediately getting a shot of amiodarone, that is amiodarone. Rhythm control is needed here. यहाँ पे क्या चाहिए आपको? rhythm को control करना है. Digoxin we give in some conditions that I'll tell you later, like atrial fibrillation we give. With heart failure we can give digoxin. Furosemide means elastics. Diuretic है तो norepinephrine, it will further increase. अगर आप दोगे heart rate और बढ़ जाएगा. There is no road. Clear? Coming to the next one, the last question. For which client should nurse conclude that prescription of digoxin is appropriate? Means digoxin आपको कहाँ देना है? अभी मेरे मुंह से निकल गया था आंसर. I just said the answer. So see one by one. Let's see one by one. In this DECG, what you can see, P, QRS, T. सब कुछ आ रहा है. Let me zoom this. P, QRS, T. So this is ECG. Where you can see, you can notice heart rate is key. If you calculate RR interval से calculate करोगे heart rate, if you calculate the heart rate will come less. So this is what. But P is there, QRS is there. So this will be your sinus bradycardia. Sinus bradycardia. Bradycardia में अगर आप digoxin दे दोगे तो पेशेंट मर जाएगा. उससे तो और हार्ट रेट कम होगा. तो digoxin, remember here, digoxin is contraindicated. Digoxin is contraindicated. इसमें क्या देना है? इसमें तो atropine देना है. You have to give atropine. I told you now. Now see the next ECG. If I see, this is what, narrow QRS or wide. अब तो सीख गए हो सब, right? Now you are learning everything. Narrow or wide QRS. Now it is wide QRS, guys. To tell me the answer, QRS wide है तो क्या होगा? Ventricular pathology, right? Real, it is ventricular pathology. So this is your fibrillatory waves आ रही है, नहीं आ रही. This is what ventricular tachycardia. This is your ventricular tachycardia. इसको short में VT बोलते हैं, right? Ventricular tachycardia में आप क्या करोगे? रिदम कंट्रोल करोगे. I told you amiodarone दोगे. पहले amiodarone दोगे. जब पेशेंट की छुट्टी करोगे तो बीटा ब्लॉकर दोगे या कैल्शियम ब्लॉकर दोगे. अगर ठीक हो जाएगा तो. Now see this one. This is what P, QRS, T, heart rate भी सही है. सब कुछ सही आ रहा है. तो this is nothing. ये तो normal है. This is your normal sinus rhythm. Normal sinus rhythm. This is your normal sinus rhythm. तो normal patient को digoxin तो देना ही नहीं है. This is not the answer. Ventricular tachycardia में I told you here what we give. Here we give amiodarone because rhythm control is needed. Now understand this. What is the answer? You can notice, if you notice यहाँ पे heart rate is very fast, right? Heart rate is very fast. You can see these are fibrillatory waves and there is no visible P waves. So this is what, this is the ECG of AF. AF means atrial fibrillation. Atrial fibrillation patient can develop heart failure. तब आप क्या दोगे? Then you will give digoxin. Right? So there are some questions, some theoretical based, some MCQ based, and I'm sure that you will get some of these questions in your NORCET exam. So wish you all the best. Be happy. ECG is nothing. Just try to see this video at least twice before your exam. आपको ये 2 बार पढ़ना. Good luck. Thank you so much. Thank you for listening to me. Take care. Bye bye.